Are you able to see that okay?
Yes. Okay, this is the case of Joe, which is not his real name. Joe is a 68-year-old retired coal miner from Cabin Creek. He worked from 1970 to 2007. He worked as an underground coal miner on Cabin Creek. He worked as a roof bolter, a mine operator, a shuttle car operator, and a section foreman. He smoked 1 pack a day from 1970 to 2007. In 2007, at the age of 55, he was diagnosed with lung cancer and stopped working. He underwent left lower lobe lobectomy and chemotherapy. He quit smoking at that time. During his course of work life, he also suffered many back injuries. He developed chronic back pain, which was treated with physical therapy, injections, and facet ablation, and chronic opioid therapy. He developed depression and anxiety at the time of his lung cancer diagnosis. He had trouble sleeping. He was treated with antidepressants, benzodiazepines, and hypnotics, which continue to this day. Joe received federal black lung benefits in 2017. He'd received Social Security disability a few years before due to his breathing, his back, his depression, and his lung cancer. Despite these many ailments, he's an active husband, grandfather, father, and community leader. He's one of the leaders of the Kanawha County Black Lung Association. His pulmonary diagnoses are progressive massive fibrosis, complicated pneumoconiosis, lung cancer survivor, and previous lobectomy. He completed pulmonary rehabilitation at Cabin Creek in 2016 and continued maintenance sessions there until the pandemic hit. He keeps regular follow-up visits with his pulmonologist, and this includes at least an annual CT scan to monitor for lung cancer. He has home oxygen, but does not require continuous oxygen. His dyspnea level is at 1 mmRC is level 3. His breathing meds are Symbicort and ProAir. Besides Symbicort and ProAir, his medications are Celebrex, cyclobenzaprine, Tramadol, 300 milligrams extended release, Q-day, Elazapram, 2 milligrams TID, Sopidem, 10 milligrams, Rapaflo, HCTZ, amlodipine, and statin. In the past 5 years, he tapered off oxycodone 10 milligrams 3 times a day, MME is 45, to his current daily tramadol dose. The physical exam on last visit at 8/19/20, a pleasant, well-hydrated man in no acute distress. His height was 5'9", his weight was 158, his BMI was 23.4, his blood pressure was 118/80, his pulse was 75, his O2 sat was 92% room air at rest, his temperature was 98.1, head normal cephalic, neck was supple, lungs, he has a healed left thoracotomy scar, scattered wheezes, heart was regular, no murmur or gallop, his abdomen is soft and no mass, extremities, no edema, back has limited range of motion. Neurologically, he's alert and oriented, and his speech is relevant. He also has a great smile and sense of humor. His stance and gait are normal. And that brings us to the spirometry. Multiple spirometries over the years. In 2016, his post-bronchodilator values were FVC 2.73, 61%, FEV1 1.81, 54%. Ratio of 66%, with a 12% improvement post-bronchodilator in FEV1. In December of 2019, at the pulmonologist, spirometry was about the same. Total lung capacity 62%, and his diffusion was 70%. Chest x-ray shows evidence of left lower lobe lobectomy and PMF. CT was also the same. His EKG is normal, despite his many years of smoking. One chronic disease he has not developed is coronary artery disease. These are our questions about the case. Is his inhaler regimen goal congruent? What was his prognosis when lung cancer diagnosed? How risky is his opioid benzo regimen? Is he a good pulmonary rehab candidate? What about home pulmonary rehab? And what severity criteria do our faculty use to interpret lung volume studies? That's all good.
Awesome. Thank you so much, Krista.
Thank you.
That was awesome. Before we jump right into any recommendations or feedback, did anyone have any clarifying questions for Krista in the case she just presented? Feel free to chat in as well. I can read it off. All right, and anyone from the hub with some feedback and recommendations for Krista? I can pull up the case as well if you'd like to see the questions again.
Actually, this is Dan. I'm over on another computer now. We're juggling computers here. And am I in the sweet spot, Mithra?
Yes, I can hear you just fine.
Okay, I know that our team here, Lisa Emery, is going to have to jump off. And this case, there's various questions about this case, but if you scroll down, Mithra, to the questions, a little farther.
I believe
Our main hub pulmonologist today is Allison, I think, unless I'm excluding someone. And I know that Lisa Emery here and I have had questions, and we've had questions at Cabin Creek too, about interpreting lung volumes. So this is a little bit, this is a diagnostic question. We can't find any good standards on interpreting lung volumes in terms of severity, like what's mild, what's moderate, what's severe. And we've seen a lot of variation in how our pulmonologists interpret that. So we just wanted maybe to know what you do, Allison. What do you call mild and moderate and severe when it comes to lung volumes?
So what I was taught with my training was the ATS standards. And when we interpret lung volumes, we're looking at the total lung capacity. And so if the total lung capacity is 80 to 120, it's normal. Above 120 is indicative of hyperinflation. Below 80 is indicative of restriction. And then what we used was 60 to 80 was mild, 40 to 60 was moderate, and below 40 was severe. And so that's what I stick with when I read the lung volumes. Does that answer your question? That was I believe it was the ATS standards was what that reference was from.
Lisa Emery, does that answer your question?
Yes, thank you so much.
We can't hear you. See if you can find the sweet spot on that mic. Back away. There you go.
Can you hear me now?
That's pretty good.
Dr. Seela, thank you so much. I got that all written down and it's perfectly clear for me now. Thank you.
Is that about what you're getting, or what are you usually getting, or does it just vary by who's reading your PFTs?
We are reading our PFTs.
Ah, okay.
But we've been unsure. But that's good enough for now. There is some more discussion, but that's good enough for now. Back to the case and the questions about the case. Thank you.
Yeah, the only other thing I would add is the other lung volume that we look at, if it's elevated, is the residual volume, the RV. And if that is greater than 140, I call that air trapping. And sometimes you can see air trapping in patients with otherwise normal spirometry and also hyperinflation, and that sometimes will prompt me to look for maybe some early COPD or some early asthma that's not otherwise showing up on the pulmonary function tests.
Great, thank you so much.
You're welcome. As far as the other questions go, the first question, is this patient's medication regimen or inhaler regimen consistent with COPD? And it certainly is not. His FEV1 was 56. Was that what it was? Post-bronchodilator 56.
Sorry, it was 54.
54%.
54. So that would be gold stage 2, moderate. And so, you know, with the first gold stage, patients should be on a LAMA. And I did not see a LAMA. I saw Symbicort and ProAir, but I did not see anything like tiotropium, like Spiriva or in cruise or anything like that. Was that correct?
I think it is, yes. And the intent of that question, Krista and I worked up this case together, and the intent of that question is to try to keep us looking at these inhaler regimens against the GOLD recommendations as a reference standard. We know that they're frequently different, sometimes for good reasons, because the original recommendations have been tried and they needed to be adjusted. But sometimes it seems there's no good reason. And also we sometimes have use of agents that aren't necessarily recommended. In certain cases, that's inhaled steroids. So we're trying to, I think our best practice is to look at those inhaler regimens and see if they match guidelines or not. And if they don't, to ask why not. Because sometimes people can be on less inhalers, or we can help them know which are the right ones according to guidelines. That was the intent of that.
So I will say, you know, if I have a patient who comes to me and is stable with their breathing, you know, they're not having any problems, their COPD is well controlled, they're not having any exacerbations, and they're not on the right regimen, sometimes I'm a little bit hesitant to change the regimen, especially if it's covered by their insurance, because once you start trying to change things, you never know what the insurance company is going to do. So there are some instances, you know, if a patient is already well controlled, but certainly, you know, following the guidelines, this patient's inhaler regimen does not follow the guidelines.
And your point about if it ain't broke, don't fix it is a great point. It's a real world practical point. And we don't want to eliminate that perspective at all.
Thank you all so much. Were there any other comments about the case or questions? And anyone can feel free to unmute and speak up as well. It's a safe space. All right, and Krista and Lisa and Dr. Doyle, did that answer all the questions about the case for you guys, or was there anything else you guys wanted to discuss with the group here?
Can I throw one in? This is Carl. I finally figured out how to get the internet, well, wandered over to somebody else's internet's actually working. The other thing I was just going to say is that you asked about severity criteria for lung volumes. I'll just throw in there that I'm super hesitant because the lung volume test, the actual test is difficult for the patient to do. And I'm super hesitant to use that by itself. If they have a weird lung volume, but normal spirometry, it's probably a problem with the lung volume test, not the not the patient. And so I just use, I look at the spirometry first and corroborate it with lung volumes right now. Now, if the residual volume is elevated, that's really helpful, but if they just have a low lung volume and normal spirometry, I don't know what to make of that.
Carl, that's a really interesting comment because we're in the habit of using lung volumes to verify a suggestion of restriction on spirometry, which is still true, but you're making a really interesting converse point that if we have a valid spirometry by preferably a NIOSH certified respiratory therapist that we can really believe, you think that that's more likely to be accurate, all other things being equal, than lung volumes, if I hear you right.
Yeah, yes, for two reasons. One is it's an easier test to do, and for this, it's less complex for the patient. The second problem, I'm gonna put my fingers up higher, is that the normal volumes for spirometry, the predicted values are really solid and have been really deeply researched, and that's not as true for the lung volume standard volume. I mean, they're a calculated value, but they're not as reliable as the ones for spirometry are, and there's not as much finesse. You know, it's just not as solid a value. And Dr. Steele, I don't know if you want to add something to that, but that's just been my, when we just looked into whether we should add lung volume, or we should add DLCO, which also has the same problem, that they've got not very good standard volumes, standard to compare to. for adding that for black lung testing. And I'd much rather have lung volumes because I actually find them more reliable and more helpful. They're diagnostically helpful, whereas the DLCO by itself, again, it's a difficult test for the patient sometimes, and it's easy to have weird answers. It's hard to make sense of.
I agree. I agree with everything Dr. Wharton said.
Thanks a million for that discussion, Hub faculty. That helps us.
There was a question about prognosis as well for this patient.
Actually, that question, well, we think he's kind of a marvel. And so we were wondering, if you were getting him, when he was diagnosed with his small cell lung cancer in 2007, what was his, if he were getting that diagnosis today, we think that 13-year survival is pretty remarkable. And we were curious what you would say about his prognosis with that condition if it were being made today.
Yeah, did he have any distant spread of disease, or was it all localized to the lung? Do you know?
We think the latter, that he did not have distant disease.
Okay, so I mean, the current stats for 5-year survival for small cell lung cancer that is localized is 27% 5-year survival. So in 5 years, 73% of patients that have this disease will be dead. So a 13-year survival is pretty remarkable. And that goes down significantly if there's any type of spread whatsoever. So, he's got the best odds if he's going to have small cell to have it localized like that, but still the odds are pretty small. So I would agree that this is a pretty remarkable to be alive and without recurrence at 13 years out.
So I would like, thank you very much. I would like, in the interest of time and getting everything else in, to flip over to our didactic. But before I do, I really want to thank Krista Critchfield for working on this case and presenting this case, and to make a plea to our GADPRC members to submit cases. And as Mithra has said to us many times, you don't have to fill in every single blank on the form. We really want to try to stay true to the ECHO model, which is didactic and case, not just long didactics. So let's try to keep coming up with the cases. We know they're out there. You guys are taking care of those people. It's a question of taking the half hour to get it on paper and send it in.
Absolutely. Thank you, Dr. Doyle. So anytime you're ready to pull it up, if you cannot share the screen, just let me know and I'll try to troubleshoot.
All right, let's give it a try here. I think we can. Okay, right now it says host disabled, participant screen sharing.
Let me try one more time. All right, let me know if that one works.
I'll just go ahead and try and share and see what happens. Okay, it's looking good. Got it?
Yes, that's perfect. We can see that.
Okay, so this didactic or this presentation, which I hope will be a group presentation, including at least Carrie Cashin here at New River, and Krista, and Johnny Mullins is with us, and Lori Mullins is with us from Roan. And several of you have actually been hands-on with this app. And I also know that the developer of the app, Cheryl Flynn, for whom it's 5:30 a.m. right now, had even made a resolution to come and join us. So she might show up yet. But basically what we would like to talk about is RT, respiratory therapist supported home pulmonary rehabilitation using a web-based app. I want to remind you that the Appalachian Pulmonary Health Project and along with APHP, our founding organization that still exists, the Grace Ann Dorney Pulmonary Rehab Centers that most of us are member of, we have 4 main goals. We want to prevent COPD, and we've done other echoes about how we're doing that. We want to expand access to quality assured spirometry in rural areas. And we just had a discussion of the challenge of quality assured DLCO and lung volumes, but also spirometry. And an aside is that Whitney Bolin from Big Sandy Healthcare, the respiratory therapist there, this week is going to Cincinnati for in-person NIOSH training. She actually found a place that is doing in-person NIOSH training and certification. They only allow 4 people at a time. So we continue to try to get all our respiratory therapists, or at least each site, to have that. Expanding access to pulmonary rehabilitation in rural areas, and that's our focus today. And then providing care management for persons with chronic lung disease. Home-based pulmonary rehabilitation is not something new. There are reports from Canada, Australia, Korea, Italy, Spain, and others going back to at least 2005 of providing home-based pulmonary rehab. Not necessarily telehealth, web-based pulmonary rehab, but pulmonary rehab mainly done in the home, often with support of visiting nurses, sometimes respiratory therapists or others. But the COVID pandemic has forced us to take a new look at it, because some people can't come in at all. Some people won't come in at all. Some people are in the midst of pulmonary rehab, and then we have to stop temporarily. So figuring out a way that we can initiate or continue pulmonary rehab at home is really timely right now. And there is new technology available which helps us to do that. Grace Ann Dorney, our founder and mentor and patron who's on this call, is continually sending us stuff. She takes a very active interest in this network. And one of the things she did earlier this year was to send this news that Medicare is now paying for cardiac and pulmonary rehab conducted via telemedicine at home for the duration of the public emergency, this pandemic emergency, which is still on. So that's key, that we now know that they will pay for it. And I'm going to change my view here so you got the full screen. Let's see. One thing that I just noticed when I was preparing this is that Australia has had telehealth pulmonary rehab for a while. And what this case report is that they figured out that there are a number of people post-COVID who have some of the same symptoms, lingering symptoms that COPD patients have. So what they did is they took their home telehealth pulmonary rehab model and applied it to post-COVID patients. And they had a series of 3 case reports here. But the key idea really is that they used the home pulmonary rehab model and applied it to COVID-19 rehabilitation. And no reason why we couldn't consider doing the same. Probably can't use G0424, but there are, as many of you know, there are other codes to do pulmonary rehab with chronic lung disease and non-COPD diagnoses. So what's going on with telehealth pulmonary rehab in West Virginia? And really, I think that means in our network. 7 months ago, on April 20th, we had an echo at which Grace Ann Dorney and Cheryl Flynn introduced a web-based telehealth app for pulmonary rehab. And I'm trying to keep our reference to web-based telehealth for pulmonary rehab, our reference is generic, but there are different brands, and the one that we were introduced to was called Health in Motion, provided by the Blue Marble Health Company of Altadena, California. And they made a generous offer, which was to let us use this free for 6 months. And depending on how you count that 6 months is going from September 1st to March 1st. We might be able to get an extension for Jackson and Roan if you start late. But basically, we have the free use of this. Taking advantage of that, 4 of our sites have begun working hands-on with this app. And those 4 sites are New River Health, Cabin Creek, Southern West Virginia Health Systems Hamlin, Southern West Virginia Health Systems Man, and Johnny Mullins is on with us from Man. And then there's 3 more that are actively looking at it, Preston, Jackson, and Roan, and all 3 of them are on this call with us right now. In working to implement home-based pulmonary rehab using the app, we've identified some milestones that will help us know if we're making progress. And I shared this with the different respiratory therapy sites, the pulmonary rehab sites that I just mentioned. One of them will be, whoops, need to go back. One thing we think will be a milestone is the first site that has 5 patients who are regularly using this app outside of the study. And the study is, there's also an NIH study going on about this, and we've been invited to participate in that, and a number of the sites are working to get ready to participate in that, but there's a lot of preparation, including having to complete city training, human subjects research training, which most of the respiratory therapists had never done before. But we also have access to this outside the study. So what we're looking at is the first site to have 5 patients who are regularly using this. New River's really close, and Cabin Creek is on the way. Another one is the first site to bill a Medicare payer for a G0424 PR session based on home PR with the app. Another one will be the first to graduate a patient who used the app for 50% or more of their sessions. And another one will be the first to bill Medicare for a monthly chronic care management visit based on using the app. And what this goal relates to is that we can continue to use the app with our patient after pulmonary rehab is completed as part of their maintenance. And if we do that, we can bill chronic care, those are billable by the respiratory therapist, billable visits under the Medicare Chronic Care Management Program. We've been talking about this for years. It's been hard to implement, but this is another opportunity to do it. I mentioned the study, the NIH study to evaluate this, and so I have a couple of what would be milestones in relation to doing the study. That would be the first to have a respiratory therapy complete city training. Brandy did it. And Johnny also did it. Congratulations, you guys. I hope you get to use your city training. And another one would be to the first of our sites to enroll a COPD patient in the NIH study. And both Cabin Creek and New River are getting close in terms of knowing how to use the app. And Southern West Virginia Health System is close in terms of having completed the city training and now need to recruit patients. One of the things I mentioned was the idea of billing for home pulmonary rehab. And none of us have done that yet. And to my knowledge, there aren't Medicare regulations or requirements or any guidance for what needs to be present to bill a G0424 pulmonary rehab session for a patient who is doing their rehab at home. And so I tried to put myself in the shoes of Medicare and say, well, what would I expect? And my suggestion is if we get close, if we get going on doing this, that I'm proposing these as criteria. Some of these are no-brainer criteria. It's like, of course you have to do that. Others are somewhat arbitrary, like for total lung capacity. What's mild, moderate, and severe? They're boundary lines, but you could move the boundary line one way or another. So number one, obviously they have to have a qualifying diagnosis of moderate or severe COPD. They have to meet Medicare criteria for who can have pulmonary rehab with COPD. Same thing, they have to have a provider referral. There has to be completion and documentation in the electronic health record of all the usual intake testing and orders that we would ordinarily do with a pulmonary rehab patient. We recommend, and what we're doing at New River, is having those patients come in for their intake here. The app that we're using does allow people to do a 6-minute, it guides people through a 6-minute walk test at home, but we're doing our 6-minute walk tests pre and post in person. Unless there's some health reason why it's absolutely impossible. Another criterion is they actually have to have the app. And this is a little bit more difficult than it's one of those easier said than done things. And there's a whole series of steps right here, but I'm hoping maybe our respiratory therapists can mention those. Okay, this is where it starts getting into, it's a real judgment call what the limits should be here. So I just threw these out. I would say that they have to complete 30 minutes or one module of new pulmonary education within the previous 7 days. Our pulmonary rehab in person is based on education, exercise, and group support. And so at home, if you're doing it, you have to have the education, you have to have the exercise. Grace Ann has been urging us to think about Zoom sessions for our home pulmonary rehab patients so they get that group support and group sense of group. We haven't done that yet. That should probably be another one of our milestones. Another one is completion of 30 minutes of exercise within the previous 36 hours. So you can see how you could say more time exercising, less time exercising, give them 48 hours. No, it has to be today, but I just put these down as proposed requirements. And then the last one is that they should have at least 20 minutes of interaction with an RT or an RN or other licensed provider to review what they're doing with their pulmonary rehab at home. What did you do for your, I see here in the app that you did 20 minutes of sit to stand exercise and 10 minutes of walking. That's great. I see how you logged that. And I see how you did the pulmonary rehab online module on COPD and lung testing. And ROS stands for review of systems. But within the app, there's actually a daily survey that they can go into, and that we're really trying to get our people, that's the first thing we have them do once they have downloaded the app and they're wanting to use it. Let's see, my screen just went away. I wonder what happened. Did the screen sharing stop, Mithra?
Yeah, the screen went black on our end. You can also try stopping the share screen and relaunching it if you had a few more slides left.
Okay, let me try that. Okay. Got it again?
Yes, we can see it again.
Okay. Let me have to see if I can. Interesting. Okay. So I was just talking about these minimum requirements. And then there are a series of steps that on this you see here on bullet number 4, I said web-based PR app downloaded and in use. And I said that's easier said than done. And first off, and this is a limit that a number of our therapists have mentioned, is that they have to have a device at home that they can use. And then they have to have internet access, and everybody doesn't have that. And then we've talked before about a number of our people, even if that exists in their home and they're older, they don't feel like they have the skill set to be able to use it. We have commonly found that the husband doesn't use email and his wife does. And so often, if we get the spouse in on it, we can make it happen. They have to have, and then we have to create an account for them, and we do that on our end. And then they have to get the app downloaded on their computer, and that's easier with some things than others. It can be hard with iPhones. It can be very hard with Android phones. Not so hard with Windows, but still it takes some effort on our end to coach the people through that so they can actually have the app on their device and it works and it's running and it's usable. Then we have to orient them to how to use it. They fill out an initial user experience. They go through an initial user experience steps, and then they're ready to go. And then on the other end is we have to be able to log on to our PAD account. So that's the end of my slides, I think. And what we wanted to do next was to actually do a little demo of this for you. And there's kind of a front end and a back end. The front end is what the patient sees when she or he logs on at home. What does it look like for them? The back end is what the respiratory therapist who's managing a group of home-based PR patients see. Blue Marble Company calls their calls that the PAT account, the Professional Analytics Tool, but it's basically an administrative account where the respiratory therapist has a dashboard where she can see who are her patients who have the app at home, and then what kind of activity have they been logging over the past week or longer. So before we jump over to that, try to screen share that. Any questions about the slides here or any comments about the slides? Or what I've been talking about in this didactic?
We just got a chat in earlier asking where the NIOSH training was taking place, and Brandy kindly chatted in, most likely it was Cincinnati, was that correct?
Hey, Dan, quick question.
Yeah.
Which is, does this app work offline? Like, and many of our patients are in hollers where the internet hasn't made it there yet. Can they use a device and do this app in some useful way, and then like bring it back, you know, after they've done it at home, bring it back to civilization and connect, or is that not a thing?
I think the answer to that is no. I don't know if Cheryl is on yet. If you are, or if someone who knows more about this, but right now, I mean, I'm a patient. I'm a test patient at both Cabin Creek and New River, and so I try to log in as a patient every couple days, and that gives some hands-on experience to the therapists. And so I cannot use this except when my Wi-Fi is working. One could imagine that could change, and that's a suggestion for Blue Marble. I think one of the reasons they like to have the Wi-Fi running is because they are uploading all the activity to their servers, to their cloud, so that they're kind of like continuously evaluating what's going on.
No, it's an interesting theory. It's just not a practical. I mean, West Virginia is not going to have universal Wi-Fi probably in my lifetime, and so I'm just trying to figure. So if the people don't have Wi-Fi at home, just move on to the next thing because you're not going to be able to do this, or at least data at home. Is that correct?
Or go have a cup of coffee at Starbucks, but that's not something most of our rural elderly patients do or can afford to do.
No, but that's why my question was if you could use it offline and then just go and connect to the Wi-Fi and let it sync at Starbucks or McDonald's, that would be pretty usable. But if you have to be connected all the time, you can go to Starbucks or McDonald's and connect. They don't really care while you're there, but they'll probably be less happy if you want to start doing a 6-minute walk test in their lobby.
Right. Right.
Hey, Dan, it's Lori. When I talked to Cheryl, we had discussed the fact that, internet and Wi-Fi, especially in Roane County, but she did state that some of those tablets do have cellular connect. So if the cellular internet data usage, if you found a patient that was actually in a good cellular data area, they could use that instead of like not having home internet or Wi-Fi.
If they know how, what they do then is they make their phone a hotspot.
Yes.
Yeah. Good point. Good point. That spreads the circle out a little farther.
Yeah, that's a lot of steps for technologically naive people.
Right. And like I said earlier, there already are a number of steps, but we have been able to coach people through those steps. I think that's our role. It's not easy here, but it is doable.
Dan, this is Grace, and I have a question. Are the web-based sessions encouraging or requiring patients to check their SAT, heart rate, blood pressure prior to exercise sessions? And is this information entered into their charts?
It's not required. There is a place to do it. And that sequence that you're talking about, a step-by-step entry into exercise is not hardwired into the app yet. So there is a place to put that in. It's not a part of the daily survey. So the daily survey that they complete and log, that tells them if they're having a green day, a yellow day, or a red day. and that feeds back to them a COPD action plan is completely symptom-based. It doesn't have those vital sign and SAT measurements of part of it, but that could be another enhancement, and it sounds like a really good one to me, to the daily survey. But the simple answer to your question is no.
I do think it would be an important enhancement, Dan, for
Yeah.
safety and for knowledge of where people are in terms of, I mean, if their SAT is 89 and they're trying to do things, or 88 or 87, really the professional, the therapist or the nurse should know that.
Yeah. I'm going to go ahead and stop this share because we want to do a different share, and I see it's 8:48, so we're watching the time here. I'm going to try a different screen share. Here, let's see how this works. It says my screen sharing is paused. I'm going to stop. I'm going to try to stop again and start again. Huh.
Yeah, we can see it says that you started sharing a screen, but it's still black, so we're unable to see what the screen actually is.
Okay, right now it says screen sharing is paused, so maybe you should cut me off and bring me back or something. Right now my screen sharing says host disabled, good.
You should be able to do it now again.
Okay, let's give it a try here. Aha. Whoop. I'm still seeing paused, and so I'm gonna stop sharing again. I'm gonna close this PowerPoint app so it just goes away. And let's try once more. It says one participant can share at a time. Yeah, it's continuing to tell me that my screen sharing is paused.
Earlier when you closed out your PowerPoint, did you click the red box that said stop sharing, or that could also be?
Okay, let's see. Okay, so I'm gonna click on stop sharing. So I clicked stop sharing, and let's see here. You know, what we might do, Mitra, is to do your survey. And I can futz around here trying to see if we can get this back so we don't lose that opportunity. Maybe real quickly. So what we wanted to do, well, maybe let's try this. We can't, at the moment, because of the screen sharing problem, we can't show you the actual app, which we wanted to do. But I would like to give the respiratory therapists who have been working with this and are with us. And I think we might have lost Krista Critchfield, I'm not sure. But Johnny has had, oh no, Krista, there you are. So, and I'm gonna get Carrie Cashin to come in here and sit at my computer because she just lost her internet connection. So why don't you come right here? So what I would like for you guys to do, and then Mitra, this might drag on, so you cut us off so that you have time to do what you need to do. But what I'm looking for is the therapist comments about what you have seen in terms of the strengths and weaknesses with your actually hands-on experience with this so far.
I think that once I get the patient over the hurdle, there's a couple major hurdles. The first one is definitely getting the app downloaded and getting it on their device. Because a hurdle for me was I've always used Apple devices. So if I have to put it on an Apple device, that's fine. If I have to do it on an Android, I feel like I'm reading a foreign language. So I got it on the Android device, which took me about 45 minutes. Like, he's done well. So after I get him over that and over the hurdle of the initial user experience, I've had a couple patients that are doing amazingly well with it. You know, they're either logging in daily or almost daily, but you got to get the right kind of patients. You need somebody that's motivated at home that you can, you know, call and say, hey, you're doing a good job, and they keep after it. So that's been pretty much my experience so far. Once I get the actual app on their device, it's going really well, but that part is really difficult.
I would tend to agree. I think the app overall is pretty user friendly, which I think most of us have agreed on that from the last meeting where we talked about this a little bit. But again, the download thing can be a little complicated. I did my first one on a laptop the other day. Sometimes just getting patients to remember to bring their devices, if they're not going to do it on a phone, to remember to bring their devices in so you can actually do that download. I had one that forgot several times. And then, you know, the Wi-Fi issue that we've talked about, I think that can be a challenge for some people. And even to go out to a place where you can access Wi-Fi in this pandemic right now, I'm not really sure who's going to go anywhere to try to sit and use Wi-Fi out in a public location. So I think that presents a little bit more of a challenge. I did have one patient the other day express that he was very frustrated that because he doesn't have COPD, and that he was very focused on it saying COPD on there, and he really, that kind of, I think he will use it, but it pushed him, I think, a little bit away from wanting to be as engaged, I feel like. Does that make sense?
Yeah. People don't like that label. I know.
Right.
One time my grandmother she never smoked ever, and she was labeled as COPD in the hospital a few months back, and she was devastated. So, yeah, I can see where some people get offensive with that label.
I just want to point out that Cheryl Flynn, the developer of Blue Marble app, has just joined us. Hi, Cheryl. And we have some good suggestions for you. We're almost out of time here because, but since you're here, do you have anything, and you don't have the benefit of everything that's gone before, but since you're here, any comments?
Yes, I apologize for logging in late. I just, the last two things that I heard, the download was confusing or can be difficult, and then the label COPD. I wanted you to know that we recently have put the app in both the Google Play App Store, and it's always been in the Apple App Store. So if they do have a Android device, it should be much simpler, and it will auto update once they download it the first time. So the only one that's a challenge at this point, or that's, you know, unusual because it's not an app store, is Windows or Mac. If someone's not using an iOS, you know, an iPad or an iPhone, they just have to download the link from an email or from our website. And then I also heard you all mention the COPD issue, and I wanted you to know that we recently launched I guess it's maybe 4 of the lessons, and we just refer to lung health as opposed to COPD. And we did that in part because we're working with University of Colorado, Denver on a project with people with COVID. And so they wanted us to remove that COPD label. And so if you think that that's something that would be beneficial for us to do for all of the other lessons, because there's more than, obviously there's more than 5. Some of them I think are really specific for COPD, so it'd be great to be able to work with you to figure out how we should reword them. Or maybe we should split 2 up and make one specifically about COPD, which you could assign to someone with COPD, and then one that's similar but has lines missing or something that just relates to general lung health or lung impairment. So yeah, we'd be happy to, you know, work on that with you guys if you're interested.
So quick question. So the people that were the techs have gone and jumped through all the hoops to load the software or to load the app not through the Google App Store, should they actually delete it and reload it through the App Store so it'll keep itself current?
I don't believe they have to delete it, but I can double check on that for you, Dan. I think if they're on an Android device, they just go to the App Store and they would download the.
My question is if the respiratory therapists have spent the time to get it to force it to download in the weird way,
Right.
are they better off to go and download it from the App Store so it'll keep itself current? That's the question.
When you say the weird way, was that the thing where you had to download the Google Play Store and then go through all those steps? Is that what you're talking about, the weird way?
No, I mean, when we had to do it on an Android device, I had to go through his phone and disable certain settings to allow it to recognize it as an app that could be downloaded.
Okay, yeah. Once it's in the Google Play Store, you shouldn't have to do that. So I don't think they have to delete it. I think they can just go to the Google Play Store and it will override the existing version. But let me double check on that. I want to make sure that I'm correct, but I believe that that is the case.
So we have about 2 minutes left. I did want to leave some time for the poll as well. Dr. Doyle, were there any other things you wanted to discuss during this session? We can certainly continue the conversation for the next time as well.
There's 30 to 40 minutes more, so you better grab the mic, Mithra.
Sounds good. Thank you all so much. And thank you, Krista, for that awesome case presentation again. And like Dr. Doyle said, we really encourage you all to just submit even questions through the online case form. Doesn't have to be a full case or anything. And thank you, Dr. Doyle, for that awesome didactic as well. So I'll just launch the poll here in a few seconds. Anytime you guys finish, just feel free to sign off, and we'll see you guys next time. Last quick announcement I do have is our next session that we'll meet is on December 7th, and Dr. Michael Roby will be providing our didactic on spirometry as a pulmonary-based health measure. So keep an eye out for that reminder as well to join for that session. So I'll go ahead and launch the poll and just let me know if there are any issues, but when you guys are done, you can just feel free to sign off. Thank you.
Same time.
Morning.
Some barriers that you face submitting case presentations. That's ridiculous. Case submission form is not user friendly.
Have a great week, guys.
Thank you.
Just 2 questions, Mithra?
Yes, it's just the 2 questions.
Well, I hope I got them right. You all have a good day. Take care.
Thank you so much. Take care.
Happy Thanksgiving. Bye-bye.
Happy Thanksgiving. Bye.
Thank you. Happy Thanksgiving, everyone.
Bye. Thank you.